Well, a warm welcome to this talk. Now, the House of Commons, the Parliament in my country, in Great Britain, has just voted in favour of assisted dying, which some people, including me, would see it as a monumental change. So what should we think about this issue? Not for me to tell you what to think. I'll tell you some of my concerns, though, and you can make up your own mind and see what you think. Now, here's some of my concerns. Trust issues. I just feel that we've got massive trust issues already in this country. Internationally, really, largely as a result of the COVID debacle of controversial interventions that were carried out, basically with the power of the state exercising control over the individual. So I think there's a big issue with trust in the state at the moment. And that's not with counting trusts in individual parliaments or governments or politicians. And also trust for the clinicians, trust for doctors. Now, trust for doctors and nurses. Now, would the assisted dying legislation further erode that trust? For example, you can imagine an old person with a terminal illness going to the doctor being a bit distrustful, or a younger person with any illness being a bit distrustful. If that's the case, it would be really unfortunate if people became distrustful of the medical authorities. Now, we've always had not for resuscitation, and then they've changed to various things. Do not attempt cardiopulmonary resuscitation. It's given various names. And in my view, and in many people's view, there was failures of this during the COVID pandemic. Often a do not resuscitate order meant do not give treatment. And it wasn't properly used in many situations. And if we had this new legislation, would this always be properly used in every situation? Or could it be misinterpreted, as not for resuscitation orders sometimes were during the pandemic, and indeed before and since the pandemic? You'll probably have your own views on that. Let me know what you think. Now, we need urgent funding reform of palliative care, need for people to have a real choice. Now, what we mean here is very often palliative care is absolutely superb. I've been privileged enough to be involved in it many times, although I largely worked in acute care, but I have done some palliative work as well. And if we get it right, we can help people to have a dignified, essentially suffering-free death in the vast majority of circumstances. And the point is, if someone comes in and we haven't got this full palliative care with our analgesics and our nerve blocks and our syringe drivers and our specialist nurses and doctors, if that's not there, the patient could be left with a situation where they have severe pain or assisted dying. We need to have good quality palliative care services so that people have a real choice. If the choice is between assisted dying and pain for severe pain, then that's not really a choice, is it? Because we're really good at palliative care. We have palliative care consultants. We're really good at this. But that choice has to be there, and that means the services have to be up to scratch. And at the moment, a lot of people don't think they are up to scratch. So people need a real choice. Could people choose assisted suicide because they feel they will not get the palliative services they need? This should never happen. But will it, given the disruption and the difficult circumstances we always work in? Then there's this idea called mission creep. Could the situation, the criteria, change over time? Now, I hesitate to put this on, but I'm going to anyway. This is the abortions in Great Britain. This is when the Abortion Act was introduced down here. Then the numbers went up dramatically and have been going up since. So would the number of assisted suicides increase dramatically? And would the criteria over time be modified, made less stringent? Could additional criteria be included? And we've looked at problems arising in the Canada situation, for example, as regards to this. If you're Canadian, let me know your experiences. So that is another concern. Cost of setting up this service. put the service in inverted commas there. How much will it cost to set that up? Could that money be better used to support palliative care services, to allow people to live well up until the point that they die, with good quality palliative care by trained palliative care specialists who are remarkably good at treating people's symptoms, including pain and distress. Now, will doctors be able to opt out or opt in? Now, this is a huge difference. Will doctors be expected to do this? Will nurses be expected to do this unless they opt out? Or will they have to opt in? And that makes a really big difference, I think. We would want to see the situation where doctors and nurses have to voluntarily opt in to participating in this treatment. And that will also have to include referrals. Will doctors have to opt in to making these referrals? So if a patient approaches their GP saying, I want to end my life, will the GP be expected to refer them? How's that going to work? Are doctors and nurses, pharmacists, physiotherapists going to be compromised by this? That would be one of my concerns. Will juniors be expected to assist seniors administering the service? So, of course, we have a hierarchy in nursing and medicine. Will juniors be expected to assist their bosses? Will the junior doctors be expected to assist the consultant? How's that going to work? And opting out when you're a junior, maybe in your 20s, 30s, and you've got a whole career in front of you, you don't want to upset the boss. It's another issue that needs to be taken into account, and as a concern I would have. Will there be any career progression implications? Will people be able to apply for all possible positions? Will they still be able to be charge nurses and consultants and sisters and senior people if they decide not to take part in assisted dying? Will the service be part of the NHS carried out in our local hospitals? Could you have a situation where one person is receiving palliative care in one bed and assisted dying in another bed? The venue situation is significant, and the staffing situation is significant. Will doctors be forced to offer the service? Will be people who are undergoing assisted dying be amenable, or not amenable, but predisposed to coercive and controlling behaviour? I've certainly been in situations, I'm sure most healthcare professionals have, where a patient asks for a treatment or asks for something, and it seems that they're being coerced by someone else. A parent, a child, a spouse, a partner. How are we going to safeguard against this coercive and controlling behaviour, which could be a pattern over a long term and may be very difficult to spot? It's a concern. Vulnerable, poor, unintelligent, demented, those without advocates. People that can't afford alternatives, people that don't understand the implications, people with dementia, those without advocates. Will the care given to a rich, intelligent, non-demented patient who has excellent advocates be the same as someone who is vulnerable, poor, unintelligent, maybe with a level of dementia with no advocates? Will the care be exactly the same? Will the criteria be exactly the same? That would be a concern of mine. How will capacity be assessed? So patients have to have capacity. How will that be assessed, and which criteria will be used? Who's going to say, you know what, this patient has got capacity to end their own life? You know what, this patient does not have capacity to end their own life. Under which criteria will capacity be assessed, and who will assess that capacity? Will the people assessing that capacity be competent capacity assessors? Who will assess psychiatric profile? Any serious illness can cause depression, which is fully reversible. So anyone who's got a serious illness is going to have a level of depression virtually inevitably, serious illness does cause depression. And when you're depressed, you don't think straight. And that's probably quite a good definition of depression, really. You feel bad. The future looks bleak. In fact, the future looks hopeless. But you're not thinking rationally. We always said that people take their own lives when the balance of their mind is disturbed. Who's going to assess the psychiatric situation? And clearly this should be someone who's very experienced in psychiatry. Is this opinion always going to be available? If people are going to die within 6 months, who's going to assess the fact that it's within 6 months to end their own life? Who's going to assess that? Who's going to be a sufficiently accurate medical prognosticator to say that? Is there going to be pressure from relatives? Are people going to say, I don't want to be a burden? We get this all the time. It's heartbreaking. Heartbreaking, looking after older people. Oh, I don't want to be a burden. Oh, I'm sorry to be a burden. Oh, I'm sorry you could be looking after someone else. We get this all the time in healthcare. And people we have to ensure that people are not ending their lives because they don't want to feel a burden. It's a concern I have. Could a right to die morph into a duty to die? Am I spending my children's and grandchildren's inheritance? And very often, ongoing care is remarkably expensive. Very often it's not paid for nationally. Individuals have to pay for their own ongoing care. Are they going to feel all this money that's being spent on me, I could be giving to my grandchildren? People should not have these pressures in deciding to end their life or not. What are the safeguards going to be for that? Any mistakes can't be undone. Two groups of people, classically the joke says, can't make the same mistake twice. One is parachutists, and the other one I can't remember. Well, I can, but I'm not going to talk about it. Extension to children mentally ill. Is this going to be, this is adults at the moment, of course, is it going to be extended to children? Is it going to be extended to the mental illness? Is a concern. Could psychiatric illness in future become a criteria for ending one's life? I think that's an issue in Canada at the moment. I'm not fully up to speed with that, but it's a concern for the future. People judge by their worth, usefulness, popularity, wealth, not being a cost, not being a burden. So people are worth keeping people alive if they're worth something, if they're useful, if they're popular, if they're wealthy, if they're not costing other people things, if they're not being a burden. This is the sort of thinking that really we can't tolerate as a civilized society. We believe that human beings have intrinsic value. Your value is not because of your bank account. It's not because of how clever and useful you are. It's not because you've got a lot of mates and are popular on social media or down the pub. Not because you're wealthy. You have intrinsic value as a human being. Volunteering for deaths must not be ever be seen as a duty. People must not feel the need to free up beds for younger people. Are judges going to interpret this law, national, international? That would be a concern. I don't really understand how this works, but very often the judiciary gets involved. Could they change the intention of the law? And norm referencing allows for a new norm. So once something becomes normalised, it leaves open the possibility for the next thing. And we get a thin edge of the wedge situation. Francis Schaeffer, the philosopher, Christian philosopher Francis Schaeffer, said something like, first of all, the unthinkable starts to happen. And once that's established as a norm, then the next unthinkable thing, which was even more unthinkable to begin with, becomes thinkable. We don't want things that are currently unthinkable to become thinkable. That's a concern I would have. It's just my personal concerns. This is just a brainstorm. Tell me what you think. Tim Farron, Member of Parliament. says this: our society has chosen a dystopian and contagious path. If choosing to facilitate the death of those who have a terminal illness rather than standing with them, weeping with them, valuing them and loving them against the desolation that any of us would feel if we were given a diagnosis of that sort. Robert Jenrick: this act, if passed, will be subject to activist judges in Strasbourg. They will change its fundamentally, and we have to prepare for that. I don't know, but Robert Jenrick thinks that's a problem. Now, of course, we could make this video last for days and give lots of counter arguments. I'm just expressing my concerns, and you can let me know whether you agree or disagree entirely. Not telling you what to think, I'm just expressing my concerns. But they are concerns based on a lot of healthcare experience, because I've worked with a lot of dying patients, and the vast majority of them, we can treat them, we can give symptom control, and the vast majority of people do die in reasonable circumstances. Of course, I'm not the one dying at that particular time. It's hard to say, but we are very good at treating symptoms, and that's as I've said, that's a specialism that needs to be developed. You see, if a patient's still got pain, one of the protocols is, if they're on morphine, double it. Just double it. If they've still got pain, double it again. If the distress, give them various drugs have been used. Haloperidol been used for distress. Different drugs are used for distress and pain. Midazolam, benzodiazepines, lorazepam, Ativan to reduce anxiety. There's a lot of things that we can give. Now, of course, if you give more and more of a drug, the patient will eventually fall asleep, become comatose as a result of that drug, and very often that drug could cause something like respiratory depression and accelerate the death of that patient. But you see, the point is, you're giving the drug to reduce the pain. So when I give drugs, or when I gave drugs, I gave drugs with the intention of reducing the pain or reducing the symptom. If the side effect of that was that the person died earlier, then that was a side effect of the medication. To me, the important thing here is intent. If I give a drug and I intended to give it to treat the pain, and the person happened to die more quickly as a result of that, that's a side effect of medication. To me, that's a world of difference from giving a drug to deliberately end a life. So to me, it's intent. If you're giving a drug to reduce the pain, then yes, death may be accelerated. But I intended to give the drug to reduce the pain, not to accelerate death. To me, it's the intent that makes the difference. But that's my view. Let me know what you think. Should we do a bit more? Yeah, well, let's do a few more things. This is an article in the Telegraph which has covered this very well. This is Tim Stanley writing in the Telegraph. We're not the same country we were yesterday. Bringing us up to date with Oregon, and we could include Switzerland, Netherlands, Canada. Bringing us up to date with Oregon, and Tim Stanley says, and I would argue this regime here. Now, we're very reluctant to make comparisons with regimes of the past, but that's what this article is doing. So let me know what you think of that. The idea of this regime of the past was death could be healthcare, necessary and kind, which I don't agree with. Clearly, don't agree with this regime in any way, shape or form. Of course not. Mr. Stanley goes on. We're not the same country we were. We do not rest on the same moral foundation. We long stuck to the principle that the state does not take innocent life. No longer. State-sponsored euthanasia was debated in 5 hours. This is from another article. I'm not quite sure where I got this, but the debate was just 5 hours. The argument for assisted dying was largely anecdotal. MPs recounted personal experience of illness and death and appeals they had from their constituents in assisted dying. Someone was unable to take the pain anymore and lay down on a railway line. Now, of course, this should never happen. But we have palliative care that can massively reduce the pain, and if necessary, the patient could become unconscious due to the amount of analgesics they were given. And I meant to check this, but I don't know how many doctors and nurses there are in the Houses of Parliament. I think there's only one nurse and probably not more than, I don't know, just several doctors. So these decisions are being made by people who are often career politicians or lawyers, or maybe not the best people, but it's what we've got. Nice to see more doctors, scientists, nurses, pharmacists in the House of Commons. Relatives will, this is a concern expressed in the articles, relatives will push the elderly to die, money will be made, the wedge will thicken. This is a concern. Let's hope that never happens. Terminally ill adults with less than 6 months to live, we're going to need 2 doctors and a judge. But again, let's hope that these criteria are maintained. Things could mission creep, let's hope not. I see it as a risk, though. British health services being so poor, this will come to be seen as a patriotic or a desperate alternative to substantive care. So the care, what this is saying is the care needs to be up to scratch so that people have a genuine choice. If you see someone standing on a bridge thinking about jumping, you don't give them a sympathetic smile, do you? Just think about it. You're walking home from work, someone's standing on a bridge, about to jump off. Evening, walk on. Telegraph says it is the post-war consensus. So we've lived with the post-war consensus. We've seen the evils of regimes of the past, particularly 1930 to 1945. We had a post-war consensus. As social, democratic as it is Judeo-Christian. That way is crumbling, giving way to something consumerist and atomizing. Death as a consumer choice, atomization being the ultimate form of fragmentation, I would think. Not an easy one. Many concerns. Let me know what you think. And thank you for watching.